Hey everyone, it's Eliana Lobo back with another one of our founders, someone who's very special to me because I happen to work at the same facility for a few of the many years that you were there, Dr. Carey Jackson. Professor Jackson is trained in internal medicine, epidemiology, and medical anthropology. He has designed health services for the medical care of refugees, immigrants, asylum seekers, and survivors of torture at Harborview Medical Center in Seattle, a teaching hospital of the University of Washington's School of Medicine. His writing and research focused on health disparities, ranging from cervical cancer, liver cancer, hepatitis B, and tuberculosis among immigrant communities. Interventions designed to address language and cultural barriers to prevention have been the focus of large community-based participatory research trials in Seattle, Washington, Vancouver, British Columbia, and a few multi-center national trials. His primary interest has been the design and operation of health services that facilitate the care of recent arrivals and limited English-speaking patients in healthcare. Centered at Harborview Medical Center, these efforts included the Northwest Health and Human Rights Coalition, together with Northwest Immigrant Rights Project and the International Rescue Committee, Refugee and Immigrant Health Promotion Program, the Community House Calls Program, and the International Medicine Clinic. He's also written on issues of language translation and the cultural construction of illness, and was the medical director of the Interpreter Services Department at Harborview Medical Center for 28 years, where he and his colleagues developed the ethnomed.org website to inform care providers, those caring for refugees and immigrants, about targeted issues in their care and cultural context. He has done field research and has taught in Guam, Nepal, Uganda, Myanmar, Thailand, and Vietnam. He was an active clinician for refugee patients for over 30 years and taught medicine on the wards of Harborview during those decades. He is an adjunct professor of global health and now an emeritus faculty member in the Department of Medicine. So happy I get this chance to interview you, Dr. Jackson, and talk to you about those early days of trying to find like minds with similar concerns about the impacts of not having language access in healthcare. So let's start with the first question. Can you speak to a few items, two or three, that propelled you on this path towards linguistic equities?
Uh, um, so briefly, I came from a bilingual family, not because of ethnic reasons, but because they were living abroad for many, many years. My father lived 14 years in Latin America. My mother was raised there until she was in her teens, from the age of 4. She was in Nicaragua. My dad was in Cuba and Chile. And so that was just part of our heritage. And then probably the next dot in the line would be extensive travel before college, after high school, for over a year, basically all over the world. And then having found that very gratifying, coming back to pursue degrees after college in epidemiology and doing field work in Guam and my master's work there, and realizing the cross-cultural nature of medical illness. And then in medical school, arriving someplace where there was a very robust medical anthropology program. And so being able to do both medical anthropology and medicine at the same time, and realizing that those things really reflected sort of my chosen area of emphasis going forward. And did my graduate work in Nepal. And there again was sort of enmeshed in shamanistic traditions and the cultural construction of illness. And so then when I arrived back to finish up my residency and was looking at fellowship, it was clear to me that I was going to pursue training that would begin to explore the interface of culture and medicine, and language is so central to culture that was inevitable.
And did that help drive your decision to come to the Pacific Northwest? How did you connect with
The fellowship? Yeah, the fellowship drove my decision to come here. It was the Robert Wood Johnson Clinical Scholars Program, and they were very open to my at that time considered very marginal interests. Now it's moved, then gradually over time began to move to the center stage when we started to talk about cross-cultural medicine or cultural humility. And then it moved even more central when we started to look at health disparities and unequal treatment and that sort of thing. And people began to realize that this was significant, especially during the pandemic, when the highest rates in our region and across the nation were among the working frontline poor that also were marginally connected to health information because of linguistic access.
So understanding there's so many different ways cultures collide. It's not just language, it's not just the culture that you were born with, but what about North American medical facility culture? That's like another world that people have to learn about in order to be able to navigate. What about this journey that took you so far in so many places around the world made you realize that language access, mainly interpretation and translation, were a fundamental piece in order for you to be able to explore, research, or treat patients?
Right. So to this crowd, it goes without saying how tricky language is and how central it is, right? So even partners are constantly nuancing word choices when they have their disagreements, right? Because as many people will point out to you that have done really extensive work on the neuroscience of language as well as the sort of phenomenology of language, that words capture only a part of our experience. And when those experiences are vastly different, now the wiggle room and the complexities and the nuances are huge. And so it's more than just language access, but that's the central first step, right? To at least be on the same page around what we're talking about. And then we'll have to figure that out. And that's why a skilled trained interpreter is so central, right? And so whenever we were developing questionnaires or trying to get histories, it became clearer and clearer that it was all passing through an interpreter who needed to know their skill, their craft, their specialty extremely well. And so in so many dimensions of what we did, that became central. The central first step was linguistic training and then obviously access for whoever
That's
it
such
was,
a
if it was a research
critical
subject or if it
piece
was a patient.
for providers to champion, really, the need for a qualified, trained interpreter rather than that family member, that convenient neighbor or coworker who was there when the person got injured, that is convenient because they're right there, but they're missing that piece of not only experience, but training. And it's not being a human dictionary, it's understanding role boundaries and ethics, and also that North American healthcare system culture to help be able to bridge the gap, which is why that program is so aptly named. What are some of the important strides that you feel the profession of healthcare interpreter has made to date? You were there at the beginning, so what do you see that interests you, that you applaud, and what would you like to see that hasn't happened yet?
At Harborview, we had some great experiences, and I'll point out a few. First was the development of a navigator program that took interpreters and expanded their role and made them cultural mediators and navigators. And that was kind of fleshed out in a study we actually did following Flores' study to look at errors in interpretation. But we added to that with methodology the idea of improved interpretation by the interpreter who annotated things, but annotated them in a positive way. And in fact, there was 10% of the encounters we looked at it on a sort of phrase by phrase basis, where interpreters actually they annotated, but they clarified things so that the provider understood better. Otherwise, they would have made a misinterpretation of what was happening there. So it became clear both in a study setting, but also in clinic on a daily basis, that interpreters not only provided access, but they also helped manage the cultural context that was below the surface of what was going on. So by having navigators step in and be allowed to expand their role to help explain medicine to their client and their patient, and also explain the client's world to the provider, the navigators were really able to facilitate care outside the clinic, also on the wards of the hospital, in the ICU, in end-of-life care, et cetera. And so that was one innovation. I think the other innovation was to specialized interpreters. We had some that primarily did cancer interpretation. And so they became very familiar with oncology workups and the logic of oncology. They were blocked in oncology and they could manage that. Others did a lot of work in psychiatry. And so they were specialized in psychiatric terminology and the sort of laws of psych that they often had to explain to families and patients about, why people were on a hold or why they couldn't have access, et cetera. And then I think that over time, it became clearer that interpretation, just like medicine, has its specialty services. And so we had somebody in the surgical suites working with the surgeons around wound care and informed consent. So as time progressed, we began to realize that this is really important to do. And then I think finally, it was the structures of interpretation where you realize, and this happened some time ago, but it was just hard to roll out across the nation. And that is realizing that the in-person interpreters often essential, but not always. There are routine kinds of instructions that are needed in translation, but you don't need people for very long. So the long sojourn to the clinic and the wait times, et cetera, are a waste of valuable interpreter time. And video interpreting or telephone interpreting becomes valuable. And this happened on our watch as well. Initially very inefficient and then increasingly efficient, so that people could get a urine from somebody who was just there to give a UA and not have to sideline an interpreter for an hour, but just use an online interpreter, a phone interpreter for the 5 minutes it took to explain the process. So that capacity to speciate interpreters, to look at their job requirements and their needs, that exploded over time. And I think that's only going to progress.
Well, that's a great example to give because the new challenge now is AI and chat GPT use in patient education and routine communication. And this is a great example to give of how interpreter function was triaged in such a way that interpreters could specialize, because especially for long-term treatments, whether it's oncology or say transplant, the family becomes just as well versed in the terminology and the acronyms as the provider. But the interpreter, who may be a trained and qualified interpreter, but may not have had much experience with a transplant patient, or even in mental health with names of some of the drugs prescribed, there's a learning curve that it's nice if it's not there. Both the patient and the provider relax into communicating more directly with each other when they don't feel that filter of the third person is present because it's so seamless. So that's a really good example, I think, to carry over to the concerns right now, trying to figure out what are the guardrails for AI use in
Right. You
language
can see it
access
coming.
in healthcare.
Right.
Yep.
It's obvious it's coming. So I think that one of the issues there that Patrick always used to bring up was small languages, right? He had in mind, I think, the Min, but there are so many Central Americans, you're from Brazil, so many native people coming in speaking Portuguese as a second language, right? Speaking Spanish as a second language. And so the assumption, of course, sometimes by the clinician is, oh, they're speaking their mother tongue, but they're working in another language that they are not particularly robust in either, right? And so, and sadly, most doctors don't communicate all that well. They speak medical speech really well, but when they're speaking to everyday people, they sometimes speak over their heads and are unaware of it, right? So now you've got two people, one speaking a language for the lay people at a register that they have a hard time really understanding, and then you have somebody translating that into a second language for somebody from a small language group. AI will find that incredibly challenging, especially with accents, right? So we'll be talking to somebody from Vietnam, and somebody else who's the interpreter from Vietnam will go, that Hue accent, that Central Vietnamese accent is so thick, or that North Vietnamese accent is so thick, I'm having a hard time with it. Or they may be hill tribes speaking Vietnamese as a second language, and the accent is prohibitive. So all of those things, I think, and word choices and how idioms are used in different parts of countries will be a challenge to AI, because AI will misread all of that stuff. The other thing that's going to be missed completely is the emotional content in the room, which we get from one another and good clinicians get, right? There is something off here, and it's not something verbal.
It's almost like AI is on the spectrum in a way. It can't read the room very well.
Right.
It's extremely literal. And how do we support that, or how do we limit the interaction to where it's safe? Certain things never change, right? Wayfinding in patients' rights and responsibilities translation, the clinic hours,
Yeah, grateful
many
for.
things. And we've never been able to assign an interpreter to sit in a room and explain all the menu choices and what the ingredients are that go into the meal that's offered for lunch or dinner. But AI could certainly do that, and patient satisfaction would definitely go up. So lots of things to think about, but we need to be in the dialogue at the planning stages. Otherwise, it's like that conversation with Epic. It's like, why is Yugoslavia and Czechoslovakia still on the language list if they're not countries anymore? And it takes
Right,
like years to get it off. Anyway,
right. No, that's true. I think the other thing that's possible besides AI are trusted interpreters, because they're often known in a hospital and a facility, giving routinized messages in short video clips and
yes,
accessible by QR codes. So then they see somebody they know, because it's all about trust,
exactly that recognition.
right? So they see a face they know, giving them a canned speech on, whatever the technical process is it's about to happen, and they trust the speaker and they can follow the instructions. And if they didn't get it the first time, it's a QR code. You play it again, you play it again, you play it again. That's something that we've also tried to explore at Harborview, and I think that they're taking it further since I retired, and that will be very useful. They're using it for fit testing. We tried to use it for COVID testing, that kind of thing, where it was just the same repeated message again and again, but you needed to hear it from somebody that you really trusted.
Yeah. I remember the Hallmark card, you could record a message
Yeah,
to
right.
someone. It's like, why can't we give them the medication instructions? Every time they open the card, it repeats. But you know, we pull from all areas, right? Because you
Yeah,
never know
we've gone forward from there. I think those QR code possibilities are great.
yes, are a much more advanced jump and less of a hurdle because that battery will run out on that
But the thing
Hallmark.
will get lost or somebody will spill Coke on it, right?
Yeah, yeah. So briefly, how would you summarize your interaction at the beginning of NCIHC to see it become an organization, to see certification become a reality and now a requirement for hire for interpreters, and your participation in getting such an awesome organization up off the ground and running?
Well, my role, I think, in the actual formal organization was more as a sort of cheerleader. With an anthropological perspective, I think I was often championing
Mhm.
the inclusion of sort of cultural context, et cetera, in the role of interpreters, and not a stripped down kind of technical role like you would have in the UN. Because I realized that when you start to talk about the body, it gets vague. When you start to talk about the cultural construction of the body and of illness, it gets even more bizarre. And so you need to make sure people are understanding one another, and that requires an expanded role. So early on, I was probably making those points, but really deferring to the others to take the formal organization of the organization further. Then as it began to grow and solidify, it was just my honor to sort of watch it from a distance as I did my work. We were sort of allies at different ends of the trenches, so to speak. And so I was always encouraging and supportive of the formal role, and grateful for it, because it rolled out training and certification and a formalized, professionalized role for interpreters that was really greatly needed. I think that I think there's a sort of labor piece here that also deserves to be said, that interpreters are grossly underpaid for what they do, and the hospitals have the challenge, and that's why AI has a certain appeal, right? Because of benefits and the other things that are the sort of hourly wage issue that people come up against with temporary workers, et cetera, and rights. And so I think that formal organization also has a protective role, and I think that's really important, as many formal representative unions and that kind of thing for interpreters have. So there are multiple layers, and I was just delighted to watch it evolve and support it where I could.
Well, we need more champions like you, Dr. Jackson. It's been a delight having a chance to chat with you again, and I wish you lots of wonderful travel experiences in this next chapter of your life, and maybe we'll see each other in Portugal.
That would be a delight. I really do have still on the list. Thank you very much.
Thank
Thank
you again. Bye
you.
bye.